Okay, this is the fourth podcast of the second PowerPoint. I'm sorry I wasn't paying attention to time and I'm not sure where I got cut off, but I was talking about the possible need for a pacemaker if this block would deteriorate. So anytime you count a QRS that's greater than 0.10, it's considered a bundle branch block. That's really all you need to know about that. That's what it looks like on a strip with a different deflection, a negative deflection, just a wide if you count this QRS. This picture depicts that there's a block here in the left ventricle bundle. So that leads us to pacemakers. A good time to talk about pacemakers since they're used commonly as a treatment for heart block. Now, we're used to a generator with leads that go to the heart and sit in the heart, but now they're coming up with new pacemakers that transmit signals and don't use leads. And that's what these are. So this is new technology that's being used. It's not widely used yet, but you could possibly see someone with one of these devices. So what do the pacemakers do? They provide a timed electrical stimulus to the heart when the heart can neither have impulse initiation on its own or the conduction system of the heart's defective. What happens is it functions just like your SA and AV node, where it creates that electrical stimulus that spreads throughout the heart. What are some indications? Well, when you need to maintain hemodynamic stability in someone who has a dysrhythmia, whether it would be just plain bradycardia or third-degree heart block or any other AV blocks. Some patients have what they call tachybrady syndrome, where they're constantly having a rapid rate and then it drops real slow and it's really inconsistent and they need something regular. And usually this happens with something wrong with the conduction system of the heart. Some patients come back from surgery and have a lot of surgical injury and actually are in asystole and need a pacemaker pretty much right away. Usually patients after valve surgery, whether it be aortic or mitral, especially, might have some heart block or bradycardia and could use a temporary pacemaker after surgery or end up needing a permanent pacemaker. Some terminology, when we say pace or fire, that the pacemaker fired or you're pacing, that means the pacemaker is emitting an electrical impulse to initiate myocardial depolarization. When we talk about sensing, the pacemaker is detecting any intrinsic activity. And what I mean by intrinsic is the heart's conduction system doing something on its own. And we can set pacemakers to look at the heart's conduction system and only work if something abnormal is or something's not happening the way it should be in the heart's own conduction system. And if it's happening like it should be, the pacemaker just stands by and watches. Capture means that you have a mechanical action after electrical, because to have effective cardiac output, you need to have both. You need to have the electrical with the mechanical. There are different types of pacemakers. Over here, this is your permanent pacemaker. These are temporary pacemaker generators that we have a couple different types of temporary. These would be generators to use for an internal, whether it's placed transvenously or the leads are placed through the epicardium. And we'll talk about external pacing here in a minute. So if we're going to use an invasive temporary pacemaker, we need to have wires that go in through the groin or in through the brachial vein that have wires that sit in the heart. Okay, and then these wires come out to a cable that would plug into the generators in the previous slide. It will go right into the right ventricle and have direct contact with the endocardium. Epicardial wires, really hard to find a good picture of these, but these are put in after cardiac surgery. They lay on the surface of the heart and they're pulled through the skin right below the chest. They're sutured in place and they can be removed before the patient goes home. You just cut the stitch and pull them out. So this will directly stimulate your epicardium. Also, these wires are hooked to cables that hook into those pulse generators that we saw in the previous slide. Sort of like these. You can have a single chamber pacemaker or a dual chamber, meaning you can only pace either or the atrium or the ventricle, but not both. A dual chamber will pace both, and sometimes they're called AV sequential pacemakers. These are examples of cables that go from the wires to the generator to connect. In an emergency, you can put wires straight into the generator, but that's not good long term because they're very short and it's easy for them to fall out. So temporary pacing externally is done with the monitor defibrillator on the crash cart, and we use these patches. We call them FAST patches. They're placed on the chest wall, on the skin of the chest wall, and the electrical impulses travel through these in through the skin to stimulate the heart. And right there and then, it should tell you that this is very uncomfortable for the patient. Very painful. The patient should have medication to be able to be a little bit more comfortable and not remember this. This is an emergency measure. This is not meant to be done for any great length of time. This is just applied till the patient can get to the cath lab and have a temporary transvenous pacer placed. So the procedure, you just don't come into the hospital and get a pacemaker if you need a permanent one. That is something that has to have scheduled time and set up. So if you come in, you're not going to get your permanent pacemaker the same day unless you've been previously scheduled for a time slot. So you'll come into the emergency room. This is something that they would initiate in the emergency room until they can get you to the cath lab and get a transvenous temporary pacemaker placed for you. Then you'll have that transvenous pacemaker until the doctors can evaluate you, run some tests, and get you scheduled in the lab for a permanent pacemaker. So this definitely would be what happens on off shifts and weekends, but even during Monday through Friday, 8 to 4, this is what happens. Like I said, people are scheduled for the lab to have pacemakers put in, and it's not something that happens emergently. So you kind of need to know the process so you know how these things are utilized. What are some complications of temporary pacing? Well, it's not a permanent thing, and these leads could become dislodged, and so you get a loss of capture. They can irritate the ventricle, so you can have PVCs. They can stimulate the diaphragm and give the patient hiccups, and that's really horrible to watch when your patient develops hiccups from a pacer. You can give them microshocks. You must touch the wires, only touch the wires with gloved hands and not your bare hands, because you would never want to give them a static shock through those wires. Of course, there's always a chance of infection because it's invasive, and you're always a chance of inappropriate pacing or sensing. Like, these are temporary, they're not meant to be used long term. Like I said before, permanent paces are permanent, they're implanted. The battery usually lasts about 10 years. It's a really easy procedure to have a battery replaced. It's not major surgery. Same thing with leads. Sometimes leads will fracture or become dysfunctional and they need to be replaced. And it's a very short procedure, something that's not major surgery. Heart failure patients tend to get enlarged ventricles, and their ventricles don't always contract at the same time. So a new therapy, not a new therapy, it's been used for a while now, but it is newer than the pacemaker, is putting in biventricular pacemakers that have leads that go to both ventricles and coordinate the action of the ventricles, because patients with heart failure will benefit from having both ventricles contracting and expelling blood at the same time. The other thing that you're most likely going to see is a combination pacemaker defibrillator. If a patient gets a defibrillator placed, it's going to have pacing capabilities. Now, if a patient's getting a pacemaker that doesn't meet the criteria for a defibrillator, it's just going to be a pacemaker. But if it's someone getting a defibrillator inserted because they meet the criteria for that, it's definitely going to have a pacemaker incorporated in it and be a combination device. Just a picture of where the generator, it sits, in your anterior chest towards your shoulder, underneath the clavicle, and how the leads go directly into the heart. So you want to manage your patient post-op with pacemaker care just like you would for any surgery. You want to monitor vital signs. You're definitely going to monitor continuous rhythm to make sure that the pacemaker is functioning appropriately. They should get a portable chest x-ray when they get back to make sure that the leads are in proper placement. They have not moved. You're going to address discomfort of that shoulder with pain medicine or Tylenol. How we prevent the dislodgement of the leads is restricting activity of the arm on the side that the pacemaker was placed. They can't lift the arm above the shoulder, and they really shouldn't be doing any pushing, pulling, or lifting with that arm. The following morning, a representative from the company that made the pacemaker that was inserted will come in and do what we call an interrogation. Make sure everything's functioning correctly with the pacemaker and that it's working the way it's supposed to. There's, discharge teaching that needs to be done with the pacemaker that includes follow-up with a physician. So what is some of that teaching? Not raising the arm above shoulder level for 6 weeks. Not lifting more than 5 to 10 pounds. This says 10, and I'll hold you to 10 on an exam, but some people are even saying 5 pounds. Learning how to take your pulse for 1 minute every day. Learning how to do incision care. You want to wash the site with soap and water, pat dry, no lotions, creams, powders to the site. What the signs and symptoms of infection are. They should always have an ID card in their wallet that indicates what type of pacemaker, the manufacturer. They could wear a medic alert bracelet if they wanted to, and they want to avoid any activity that's going to have direct impact to the generator. No shooting a gun that could recoil back into that device. No contact sports. They even limit golf for a while. You can eventually do golf again, but they want to make sure that you're healed and those leads are in place and they're not going to get dislodged from your arm movement. So you're going to say, so what do we need to know about pacemakers? Well, you want to know the basics of how they work. You want to know what post-op care and teaching to do for your patient. And you're going to want to know that their appearance on an EKG is a little altered when they have a pacemaker working. So some of these things that I'm going to go over here, you do not need to focus on. Just what the settings are, the rate. That's the rate we set that we want the pacemaker to fire. The sensitivity. How sensitive do we want it to what the patient's doing? Do we want it to be very sensitive so that it only works when the patient's own conduction system's not working? Or do we not care and we just want to pace when we want to pace? And then the MA is the amount of electricity that we have to deliver to get the mechanical capture that we're looking for. Some basic modes. Synchronous is demand, meaning it is sensing the patient's own intrinsic activity, and it only fires if it's needed to, aka demand, when it's demanded to. The heart rate falls below a set rate, the pacemaker will kick in and fire. We usually set up our temporary pacemakers this way. Asynchronous is when we're not looking at what the patient's doing, because usually they're not doing much of anything, and we're just going to fire regardless of what they're doing. I will pick up the next podcast finishing discussing this since I'm running out of time.